Can you give kind of the audience a little background on who you are, what you're doing, what kind of gets you excited as a clinician, and then we'll go from there.
My name's Dr. Sean Altman, and my background is going all the way back to just basic medical training. I at one point, even in high school, I was an emergency medical technician. I've been a personal trainer for 25 years. Still do that a little bit on the side. I pursued physical therapy. Actually, I was just answering this as a question. Someone was asking me some questions about my history. So when I was just out of undergrad, working as an EMT, I recognized my father was having a heart attack on the softball field and got him into the ambulance. And he ended up having triple bypass surgery. And then he did cardiac rehab 3 days a week, and I was inspired by his therapist there. The one on one attention they gave him, how they were able to help him restore his function, get his life back, get his vitality back. It really inspired me to look into physical therapy, which I hadn't even heard of prior to that point. I didn't really even know much about it. And from there I went to PT school, and I've always had that desire to really be intimately involved in a person's rehab and their care and help them through the whole process of getting better. Um, and out of school, I worked in the outpatient orthopedic realm, seeing knee replacements and post-surgical, typical orthopedic stuff. And then I got involved in working in a chronic pain clinic with a physiatrist who I'm still very close with. And it was really in that setting that I started to learn about alternative modalities. So I realized in these particular patients, with the complexity of their issues, be it fibromyalgia, Lyme disease, rheumatoid arthritis, more complicated issues, they didn't respond to the traditional therapies. And then a lot of them, due to their advanced age and medical comorbidities, were not good candidates for things like orthopedic surgeries. So from there, I started to look into alternative treatments, alternative modalities, things like cold laser therapy and shockwave, dry needling. And then working in this setting, I also learned a lot about orthobiologics, PRP, stem cells, all of the regenerative placental matrix, all of the regenerative treatments, that are really becoming much more popular now. But this was like 15 years ago. So we were kind of on the cutting edge, on the forefront of a lot of these things. And then it really inspired in me this journey into functional medicine and looking at how the body works, the overall health of the body, the nervous system, what affects the inflammatory response, what are those external factors that we can manipulate and adjust to accelerate healing in patients, or even to facilitate healing in patients who are not able to heal from various issues.
Now, I know a lot of people are going to hear functional medicine and immediately they're going to want to hear more about this. So I have to go down that road a little bit.
Absolutely.
What is your training? What is your certification? I know a couple other therapists that went down that road. Give me a little more specifics about your background in functional medicine.
Sure. So I haven't gotten the official certification, but I've done a bunch of courses through IFM, which is the Institute of Functional Medicine. Um, and I really use my training more, in the context of musculoskeletal medicine, orthopedic medicine. I could obviously, people who are IFM certified will often take a really active role in supplements and much more in depth in terms of the types of things people are taking. For me, it's more just like looking at their whole life balance, activity level, diet, sleep, heart rate variability, looking at, factors that influence exercise and health. and just looking at that in the whole greater scheme of things, because that can often interfere with a person getting better, or even just at the very least, it can significantly slow down the healing process.
And I've got to think like we're all evolving in that direction, I mean, and I've always had this conflict in my mind where I was like, before I was a physical therapist, I was a personal trainer, a strength coach. I loved physiology, I loved anatomy. It was so simple to look at the body like a machine, like a robot. And
Hmm.
when, A plus B equals C, the world is good. And then
Yeah,
I remember very similar to you, like my mom, I was doing an internship for my undergrad in kinesiology from Penn State. My mom had developed frozen shoulder. She had developed diabetes, type 2 diabetes. She wasn't managing her blood sugar as well. It was this collection of symptoms. She was a smoker, high stress, sleeping poorly, like everything you can pile on right out of the textbook for why she's got this shoulder issue. I didn't know any of this at the time. I'm trying to understand, like in my mind, it's mechanics. It's, this is the way the glenohumeral joint moves and why is it not doing it? And so I think with time, we start to realize that in PT school, at least this was my experience, you learn how to treat injuries, but we're not always dealing with injuries. So much of what we're dealing with is lifestyle. It's so much more complex. There's so many other variables and factors that come into play. Yeah, if I get a kid who's running and jumping hurdles and ruptures an ACL, pretty easy, pretty straightforward.
yeah.
But when I've got somebody who's dealing with 50 comorbidities and complexities and lifestyle and socioeconomic factors and all this other stuff, man, the things we learned in school just don't apply anymore. It's a whole new world. So with that, you are somebody that obviously has done well both in school, but then also just self-taught, self-guided
Mhm.
education. You're learning, you're researching, you're looking for these answers. How do you reconcile? Because this is where I struggle. How do you reconcile the balance between, okay, this is a modality that, maybe the clinical research, and I'm saying any modality, maybe the clinical research isn't so great. We've got product companies that are pumping out stuff that they're claiming that maybe isn't really that well supported by objective clinical data, but we use it and we see benefit in some cases. We don't see benefit in other cases. I always struggle, and I've struggled for 20 years with, do I do something that I don't understand that might provide benefit to my patient? Do I do something that I think might be on the placebo side of the bell curve, but still is not harmful and may provide benefit? Like, how do you find for yourself professionally the balance between trying an intervention that might not be clinically supported, but it might help? What do you do in those situations?
So it's very interesting that you mentioned that, because my thinking on this has changed dramatically over the course of my career. So my original background is in molecular biology, and I have a very heavy research background. I actually did um, the original preclinical trials on turmeric, curcumin, like that, and we did prove that it worked. And when you think about like scientific research, and even, drug research, there's, very high level of standards, like the studies are very sound, but it's because of the nature of how the studies are set up. It's very easy to test a drug against a placebo. When you're talking about physical modalities and when you're talking about treatment, something like physical therapy or physical medicine, you're usually using multiple modalities at the same time. So it becomes immediately very difficult to prove that things are working. And then there's the ethics of like, do you do lots of control groups, placebo groups, and deny people treatment that might actually really help them? And then on, even further down the line, there's the political part of like getting funding for these types of studies, which can also be very difficult. So I would say where I reconcile these things is in the science. So if I'm interested in a particular modality, I put on my science hat and I study it intensely. I study, how the modality works, the scientific basis for it. And even if there aren't clinical studies, there are often scientific trials like showing on a chemical level, on an electrical level, what the modality is doing. And then at that point, if I feel like the science is sound and there's a good foundation behind it, then I think, is this going to be the right modality clinically for my patient, and is it going to help them? And if I think that that's the case, then I think it's worth trying, because we know that the research is always behind the modalities, because of the politics, the funding, all of these things. And it also just, it takes a long amount of time to prove beyond a level of a certain doubt that things work well. I had this conversation with one of my colleagues who's a orthobiologic physician. He does, stem cells and all that. So I spoke with his mentor, who has been doing PRP and stem cells for like 35 or 40 years. He was one of the first people in America to do it. And this was over some drinks. He said, for the first 15 years, I had no clue how it worked. I didn't, he was like, we were just trying it. And then we realized we were getting good results. But for a long period of time, there was no research on it. And they were like, well, hey, we might as well give it a shot.
I mean, I can empathize with that. I understand that. And I feel like maybe I'm hitting that point in my career once again where, as a novice clinician, like everything is amazing, everything blows you away. And then as a more matured clinician, you're like, nothing works. It's all placebo. Even exercise is largely placebo at the dosing we're delivering to our clients. But now I'm kind of hitting that world again where I'm like, you know what? People are just looking for a solution. Who am I to take that away from them? As long as I'm not causing harm, as long
Mhm.
as they're not mortgaging the house to afford this, let's at least give them a chance. And you said it, we had this conversation before. We're specifically talking about people that haven't been responsive to conventional conservative care. I love exercise. I want to fix everything with exercise, but exercise doesn't fix everything. And no, and people aren't always appropriate for the right dose of exercise at the right intensity and the right mode. And so I'm like, I need to find other things at this stage in my career. Let's get into shockwave. And
Mhm.
I'm going to come to this, like I said, as a complete novice. When I talk to patients in my clinic today, I don't have the machine yet. But when I talk about shockwave, their first thought is electricity. It's electric modality. They ask me if it's tens. They ask me what it is. I asked ChatGPT the other day, what's the difference between shockwave and ultrasound? Because I can't even say what the difference is between therapeutic ultrasound and shockwave. How do you describe the difference in the modality and what the modality actually is?
So it's the application of sound waves, just like ultrasound, but it's obviously at a higher intensity, a higher frequency, and enough power that there's energy being delivered. And all of these modalities, be it cold laser therapy, shockwave, TENS, I mean, they're all methods of delivering some form of energy. And we, in functional medicine, we call it energy medicine, because it's just different ways of delivering energy. The differences are that they're different types of energy. So it could be electrical energy, it could be light energy like laser, or in this case it's mechanical energy, through the sound waves. And those sound waves deliver energy into the area, and then increase blood flow and local metabolism, and help with decreasing inflammation in the area, and can help facilitate healing. Um, and adding energy to tissue can make it more pliable. So we talked about how we can use it, for things like frozen shoulder. But it's basically just one other version of energy medicine. Um, and I would say one of its biggest advantages is its ability to decrease inflammation and break up scar tissue and tightened muscles, like fibrotic tissue. So one of the things that shockwave has really been known for, and I would say it's probably the best treatment for something like plantar fasciitis, because it's able to really get into that area, the plantar fascia, break up those fascial adhesions, and decrease the inflammation without creating an inflammatory response. So if you think about plantar fasciitis, if you use something like, say, a Graston tool, or you do deep tissue massage, or you have the person rolling it out on, a tennis ball or something like that, you're going to break up those fascial, adhesions, but then that friction, that rubbing, that intensity is going to cause an inflammatory response. And then what happens to the body when there's inflammation and increased discomfort in the area? The muscles tighten back up, the fascia tightens back up. And that's what makes it such a challenging diagnosis to treat, is because it's very hard to break up that tightness and keep the inflammation down to a certain level. And that's, one of the things that shockwave allows you to do, is to do both at the same time.
Okay, I want to ask you 2 questions. I don't want to forget the second question, so I'm going to
Yeah.
tell you right now. Question number 1 I'm going to ask you is about energy and energy types, because I
Hmm.
get very uncomfortable when we start talking about energy, but I want to put this into physics and mechanics.
Absolutely.
The other question is about inflammation itself. I want to understand how you use the word inflammation, because I think I'm using the word differently, but talking about energy. So I can understand, and I can go along with energy from sound waves being a wave that actually creates a vibration, perhaps in the tissue. That vibration creates warmth, creates friction, maybe increases the temperature, or has a mechanical effect. Different kinds of energy, to my understanding, are used in different ways. Now, my car is sitting outside with light shining on it. That light energy is not filling the gas tank, because my car is designed to run on fuel, on gas. But if
Hmm.
it was, a solar powered electric car, then that light energy would create energy that's usable by the battery in the car. So
Hmm.
when we're looking at this from an energy perspective, putting energy into the system, am I right to say, okay, sound is having a mechanical effect by
Yes.
actually vibrating and moving the tissue?
It's adding energy to the tissue, and then it makes the tissue more mobile, and then the energy in the area is also cellular energy. So the mitochondria and the cells in the area are able to use that energy to carry out cellular processes.
Okay.
um, because sometimes, our inability to heal from various issues can also just be from energy crisis in the area, that there's just not enough energy, cellular energy in the area to complete the job,
Is
because we're
this
using it elsewhere. And
Is
this
this
is
something is this something that could be objectively measured or seen? Like, I know we talked about ultrasound. Well, we talked about therapeutic ultrasound a minute ago, but in our previous conversation, we talked about imaging ultrasound.
yes.
How does that tie into this?
So I have musculoskeletal ultrasound at all my offices, and I do use it to essentially show that there's an effect being made. Um, so an example would be, like, let's say we're doing shockwave for plantar fasciitis. I can do an initial ultrasound scan, see the area of inflammation, look at the histologic differences in the tissue, see the scarring and the tightening of the tissue, because it looks different on the ultrasound if it's tight versus like a normal muscle, or normal fascia. And then we can do the treatment, and then we can image afterward and confirm that there's been a change that has occurred.
Okay.
That's objective. Of course, there's also the objective fact that the patient says that it hurts less,
Right.
but there's a subjective element to that.
Yeah.
Whereas the ultrasound is purely objective, we can actually see change, and then using that, we can prove that the modality has done something.
Gotcha. And you do use shockwave therapy in your interventions and treatments.
Hmm. Yep.
Okay.
And I do frequent ultrasounds at a baseline, and then just along a patient's journey as a means of tracking their progress objectively, and also determining if interventions are being effective, if they're helping.
Now, I've never used that kind of ultrasound imaging technology. Could you see, and I'm just curious, could you see a difference if client walks in, forget the other modalities, you sound it, you see it, you get them to do a workout, an exercise routine, and then you sound it again? Is there a difference in the tissue? Can you see that with the imaging?
So with the ultras, yeah. I mean, as a result, if you just did exercise, not necessarily, but with the, with the effect of the shockwave, yes. Obviously, how much of a difference is going to depend on the person and the severity of the issue and all that. But yeah, you would be able to tell if something worked or say if it did not work. And I would say that's equally valuable, because knowing if something's being effective also is really important. Certainly, I'm not going to have someone do multiple treatments of something if I don't think it's going to be effective.
Right. Now, I'm super curious about the terminology of inflammation. When I say inflammation, and I go back to, I think about being a athlete and getting hurt, and somebody says, put ice on this because it removes inflammation. And then I think of PT school and I hear of all these things that remove inflammation, treat inflammation, manage inflammation. In my mind, inflammation is a chemical response. There's cellular changes, there's chemistry that's happening. There's signs of inflammation, right? Pain is a sign of inflammation, redness, warmth. Um, but inflammation at its core, to my understanding, and I'm totally happy to be wrong, is a chemical process. It's the immune system. It's our body recovering, local injury on a cellular level. So when we say that something changes inflammation or the inflammatory process, like in your world, what does that mean? How do you use the word of inflammation, and how does this all tie together?
So for me, um, my goal is to normalize the inflammatory process.
What's
So,
abnormal inflammatory process?
so depending on the person, so if we're not looking at a healthy, athlete who doesn't have comorbidities, our inflammatory responses are typically exaggerated, as in
Okay.
there's too much inflammation, there's too much of a response in the area. So I'm just trying to decrease the inflammation to the appropriate level so that healing and the appropriate processes can occur.
Got
Um, and then let the body do its thing. But yeah, when I'm working with a patient who has an autoimmune disease, that person always has inflammation. And then when they have an injury, they have tons of inflammation, and their body does not have the resources to get them out of that flared up phase. So I'm trying to get them to a normal phase where the inflammation is read appropriately and they're able to get out of that inflammation phase. We talk about like healing as the inflammatory, proliferative, and maturation phase. You remember the
Yeah.
three phases of healing.
Right.
Um, so when I think about someone with an acute injury, you know, there's this debate recently with heat versus ice versus that. I think about it like normalizing the amount of inflammation. So, that I think is what we're trying to shoot for. So if someone, sprains their ankle and they have like a little bit of inflammation, but they're not having a big inflammatory response, then yeah, we may elect to avoid ice in that person and give heat and encourage healing. If they have a bad ankle sprain and their ankle is 3 times its size and there's 20 cc's of fluid in their ankle, that's too much inflammation. Heat is not going to be a good idea in that person. That's going to cause increased blood flow to the area and probably more pain. So, I treat it as a case by case basis based on the patient's, factors, based on the severity of injury and their response to that particular injury. And then when we talk about like chronic injuries, things like tendonitis, those patients are stuck in that inflammatory phase. There's too much inflammation in the area and too many chemical reactions going on that they can't get beyond that. So dropping the inflammation a little bit allows them to move into that next phase. And then, of course, we need the appropriate exercise and load to, increase the thickness of the tendon and eccentrics, et cetera, to, complete that healing process. But yeah, I think of the healing response as like this long process that, there's often areas along that phase that people get stuck in, and just getting them out of that little rut can help them get to the end.
Yeah.
And that's really the approach that I take with patients, is empowering them, telling them right off the bat, like, my goal is to help you help yourself get better. And that's like what exercise is all about. So, we're going to use these modalities. We're going to improve your health. We're going to improve your inflammation, your sleep, etc., your nervous system, so that you can get yourself better, so that
Yeah.
you can live a healthier life. Um, Rather than making them feel dependent on seeing me to get better.
And I think that's the greatest value that we deliver as clinicians in general. It's like, you just laid out beautifully how complex what an otherwise simple diagnosis really can be. Are we talking about plantar fasciitis in a 19-year-old cross country runner? Or are we talking about it in a 68-year-old individual with autoimmune conditions and other things? Like, are we talking about somebody who responds well to certain, interventions and modalities versus another person? What's their pre-existing condition? There are so many variables. But I think to the layperson, you get a diagnosis, you're like, oh, this is the problem. Let's fix it. What's the solution? Well, that could be 50 different solutions, 100 different
Absolutely.
solutions. It's so dependent on where you are at the moment. And even for that, like, I'm 49, I'm going to be 50 soon. What worked for me 3 years ago doesn't work for me today. I am in a completely different body today, chemically, physically, psychologically. Like,
Yeah.
we have to be able to adapt. I wish we could bring that out into public messaging a little more, because I
Mhm.
still think when people hear about physical therapist or physical therapy, it's like, we're technicians and we're going to make you exercise. And what's the best exercise for back pain? Well, that's just a complete waste of time. Like, why
Yeah.
is that? So tell me a little more about your current practice operation. Like, it sounds like you were working in a couple of different places, but you're independent. Is that right?
Yeah, I'm independent. I work in a few doctors' offices, and all of them are collaborative atmospheres where I interface, directly with the doctors, and we discuss patient cases together and come up with solutions. And it's really the ideal, part of like how we should operate, I think, as clinicians, where we're working hand in hand with the doctors and discussing, what are the right treatments for these patients, what are the things we think are going on, what do we think they should do next. And I've been doing that for a lot of my career, collaborating just in general, because that's how you understand the big picture better, is working with other, clinicians, other specialists, other people, and just getting their perspective. And I've tried to, I try to pick up as much as I can from every person I work with and integrate that into my, more global sort of hybrid approach. So I started off, in the similar role of a lot of PTs, working for larger groups, managing offices, and in the process of doing that, I networked with a lot of different medical specialties. Just initially in the efforts of bringing in new business, bringing in new referrals. Um, but I was always intrigued by each different specialty and what they did, and tried to learn from each of them. from the perspective of like how would I know when someone needs acupuncture or needs massage therapy or needs to start doing Pilates for maintenance. So I always wanted to learn about what everyone else was doing, from a referral standpoint. And then as I'm learning this, I'm also learning about their philosophies and their approaches and their perspective. Um, and I ended up becoming close with a lot of the people I networked with, and eventually opportunities came up to work with them more directly, and that's sort of where that led to some of these opportunities that I've gotten into.
This is
um
this is a
it's
great example because I think tomorrow or pretty soon I'm going to be interviewing Dana Strauss. Have you ever heard of her or watched any of her interviews?
I haven't, but I've heard the name. Tell me
She
more about.
she has great content talking about PTs, wanting a seat at the table. PTs, we're going to talk about moving toward that kind of role as primary care providers. But she was saying, we're not even in the room. Like, you are the perfect example of the therapist that's in the room. You're sitting amongst peers. You're no longer the technician. You're no longer the one that gets the referral that says, do ultrasound at 3 megahertz for 8 minutes on the right hip. Like,
Yes.
you are a functioning, contributing member of the healthcare team. And while I know therapists have the knowledge base to do that, they haven't gotten in the right rooms yet to do that.
And
You
it's
know,
hard. It's very hard to get in there in the room. And outside of these offices I work at, the respect still is not there.
yeah,
um but we're earning our respect, and that, it's a process. And what Dana's doing, I mean, that's fantastic. Like that is hopefully the future of physical therapy.
yeah.
Like there are now, with direct access was a big change. There are now some states where PTs can order imaging. That's a big change. The musculoskeletal ultrasound is also a big we're moving in the right direction. And hopefully we continue to move in that way. And it takes one person at a time, and it also takes people like her and like you putting out content to a lot of others about these types of things. And it's inspiring. It's the type of stuff that I really want to become more involved with, getting this
You
message out there to a larger audience, to patients, to other clinicians, to to help us change our status in the medical field.
Yeah,
um
I think it's a natural progression. I've got my patient-facing content on YouTube and Facebook. I've got my peer-to-peer, content on Facebook and YouTube. You're certainly moving that direction just by being here and sharing this information. Before we wrap up, let me ask just a little bit, and you don't have to give me specifics, but tell me a little bit about your business model. Do you accept insurance? Are you largely cash based? Like, how does that work? And when you're working with patients, specifically doing shockwave, is that a self-pay service or is that something you roll into insurance covered services? Just give me an idea.
so I'm completely cash based, out of network provider. I create invoices for all of my patients so they can submit to insurance, and I do my due diligence and make sure that everything that is on the invoice is reimbursable and can be submitted. And for people who have private pay insurances, some of them will get reimbursed back. It's never a guarantee. And then I come up with a a payment arrangement with each patient in terms of what they can afford. Um, Usually, the shockwave is done as part of a complete plan, because I don't typically see it as like a individual modality. If I'm going to use it to soften the tissue, I'm also going to want to do manual therapy and exercise in conjunction with the treatment. you know as we said earlier, it's often a multimodality treatment, so it will be lumped into the treatment. But when I'm treating patients and using higher end modalities like shockwave or laser or frequency specific microcurrent, there's this particular electric modality I use. Then they just have like kind of a higher tiered visit fee. as opposed to like just a traditional therapy session that's manual therapy and exercise. And all of them do this with the understanding that these modalities are going to accelerate their recovery, and it's going to ultimately lead to less visits. So we're all on the same page. I make sure they understand, yes, it may cost you a little bit more to do these types of things, but it's going to help you get better in 6 to 8 visits instead of maybe 12 or 14 visits. Or it's going to keep you, away from needing orthopedic surgery, which, is going to kill 6 to 9 months of your running season versus getting you better in 2 to 4 weeks without it. Those so it's all in the context of like the conversation, and the the patient rapport is essential for them to understand, I'm on their team and this is just me trying to help them with the very best of tools and modalities available.
And how do you build that rapport? Because I know I'm going to share this with my group of therapists who have taken my zero to paid course. And, are patients coming to you because the physician referral and the physician said, look, this is the guy, he's different from everybody else? Are patients coming to you because of Facebook ads and Google ads? Like, how are you finding these individuals, and how do they come with such a high level of trust that they understand you're doing something different?
So a lot of the patients come to me via physician referral, word of mouth, those types of things. My online presence is not strong. Like I don't have Facebook ads and things like that. Um, they in a lot of cases know that I treat differently. And if they don't, some of them, some of my patients more recently are coming just for the ultrasound exam. I have colleagues of mine that have unique patients where they just aren't sure what's going on. It just doesn't, something doesn't add up. They're not certain as to why they're not getting better. So someone will come to me for just the examination. And by doing that and doing a physical exam and, explaining things, I distinguish myself. I show them that, I'm not the typical PT and I have this additional experience and training and understanding, and then I win them over that way. Yeah, it's interesting. I've had two patients recently um with SI joint issues where they were getting really severe like coccyx pain. um and both of them, it turned out, had tears in their sacrococcygeal ligament. You might have to look that one up because I did. But essentially, it was causing instability of their coccyx. So their coccyx was flexing and extending, causing pain with sitting, pain with rising from sitting. So I was able to identify that on the imaging, and now we have a plan in place to help with that ligament repairing itself. But just a very unique diagnosis, something that, doesn't typically show up, and certainly is not seen often in the clinic.
That
Um,
that's another interview that I'm looking forward to. Ryan Martin for the musculoskeletal ultrasound diagnostic. Like,
yep,
it's
he's
a
I trained with Ryan and Colin, and
yeah.
they're amazing, and they're also doing a great job of helping us get a seat at the table. You
I
know,
mean, again, it's one of those things where you're the first person that I've heard. And I thought about this because we've got a couple non-surgical orthopedics here in town. One of them will do ultrasound diagnostics, but they don't like it. They don't have the time for it. It costs them money, basically. And
it's
so,
there's the reimbursement is so poor
yeah.
that it's not worth the time.
So
Which is why it makes its way into like cash based or other formats.
So when
Um,
I'm battling for referrals because they're all hospital employed, but there are no PTs at the hospital doing it, that gives them an excuse. The docs want to send to me because I've known them since before they were employed by the hospital. They know the quality, they know the experience, they know what they're going to get if they send their patients to me versus an in-house therapist, but they can't. But now if I bring in something like a shockwave that nobody else has, a diagnostic ultrasound that nobody else can do. Like, these are things that bring those referrals back out of the hospital system. And it gives us the opportunity to connect with patients that we would never have had access to before. I want to be respectful. I went way over the time that I had planned. What is the best way for people that want to connect with you? They want to kind of start following you. I know you're going to start putting more social media content
I
out
will.
there.
I promise I will.
What's
But
your best platform for people to connect with you?
so I'm on LinkedIn the most,
Okay.
because I do a lot of like academic and professional networking. So I would say that's the best way to connect with me. And then, I'm always free with sharing my email and phone number, because, I I have always loved networking and learning from different clinicians, different people. I feel like that's how I've grown over the course of my career, and it's the way I'll continue to grow.
Yeah.
Um, yeah, I
Yeah.
had an interesting knee replacement case that I saw today. One of my colleagues had me take a look at her, and I know you'll appreciate this because that's your
Yeah.
niche. So she's about 8 weeks out and was doing very well, with, doing traditional PT, but now she has lost, her knee extension, and her knee flexion has backed off to about 80 degrees, and
Wow.
she's getting swelling behind her knee and pain and difficulty walking. And I talked to her about the timeline of, with 6 to 8 weeks is when we start to develop scar tissue. And, it's possible that you may have some scarring that's developed as a result of, not stretching it enough, or, some combination of things, and this is where the ultrasound is useful. I can have her come in and we can identify if there's some scar tissue that's coming in. And that, would, confirm my suspicions and obviously tell us that we need to push against it and break it up. Or if there happens to be an issue with the knee, we'd be able to find that out as well. As well as I do, no one is getting an MRI on an 8 week old knee replacement. So, she's not going to get answers any other way.
Right.
So this puts the power into our hands to be able to give us our patients objective, important information, help them understand what's going on, come up with a plan, and get them back on track.
See, I had no idea that you would be able to see something like that using
Mhm.
the ultrasound system. Man, so we need to do another conversation talking about other things. I mean, we could set up a whole series because there are so many topics. You and I didn't even get deep into more of the functional medicine, holistic approach. Okay, I don't want to take up any more of your time. Stay right there. I will share your contact information in the video description for anybody watching. Thank you so much for joining me today.
Thank you. I really appreciate it.